What if the reason a chronic wound isn't healing isn't just from inside the wound? What if the problem is at the wound edge? So, a wound that has been there for weeks, maybe months, the wound bed has been cleaned, the dressings have been changed, has been considered, blood flow has been evaluated, and yet the wound is not closing. So, what happens when we stop looking at the center of the wound and start looking at the edge of the wound? So, today we're going to talk about a novel debridement concept called edge trenching. And this technique is quite novel, but it actually challenges traditional idea that debridement is simple, more than just moving around or cutting off parts of the wound, right? I shouldn't say cutting up parts, but cutting debridement is debridement in my head. Just removing all the dead, devitalized necrotic tissue. So who came up with the concept of edge trenching? And it's a new wound debridement technique. Edge trenching sounds super cool, right? That was introduced by a doctor called Dr. Igor Melnichuk, forgive me. So let me spell it Melnychuk. Melnichuk. Dr. Igor Melnichuk. He is a wound care specialist and clinical assistant professor at Edward via College of Osteopathic Medicine. So apparently, he first presented this concept at the Symposium of Advanced Wound Care in 2021, so very recent, and later published a first peer-reviewed case report in the Journal of Wound Care in 2023. So that's less than 3 years ago. So, what problem does edge trenching solve? So, the technique was designed for chronic wounds that have vertical wound edges, epibolies. We know what epibolies are, rolled wound edges, hypergranulation that never connects with the wound margin, and the wound base that appears healthy but does not merge with the wound edge, or like a deep plantar diabetic foot ulcer where traditional 45-degree bevel edge cannot safely be created. So normally we bevel wound edges approximately at 45 degrees because the keratinocytes can migrate much better over a gradual slope than a vertical wall. But when that is impossible, edge trenching creates this new transition zone, which is awesome. So let me continue with what edge trenching is. The concept of edge trenching involves targeted debridement of the wound margin and the immediate adjacent tissue to address tissue that may be non-viable, hyperkeratotic, callous, rolled, undermined, epithelialized, fibrotic, and mechanically restricted. So the central idea is quite simple: a wound that cannot epithelialize across the edge that is biologically or biochemically or mechanically unfavorable. So traditional wound debridement often focus on the wound bed, but chronic wounds have a dysfunctional border, and the border may be preventing the epithelial migration. So the analogy is simple. Imagine a cliff separating two pieces of land, and the wound bed is on one side of the cliff, and the skin edge is on the other side. And the cells cannot easily climb to a vertical cliff. So, edge trenching converts the cliff into a ramp, and the new tissue fills the trench, acts like a gradual rising path, allowing the fibroblasts, the blood vessels, the keratinocytes to move across the wound margins and complete the healing. So, how does this theoretically work? So, the proposed mechanism is freshly injuries especially injures, I'll say injuries, especially injures the junction between the wound wall and the wound base. And this causes a platelet activation, which release the amazing growth factors that we need. This helps restart the inflammatory phase. That's why patients we love to do wound debridement. Of course, vascular clearance, we have to make sure your blood flow is good, but wound debridement is key. And this also allows the fibroblasts to produce new collagen. The collagen fibers cross-link between the wound base and the wound edge, and this creates a nice smooth angle that permits epithelial migration. And that's what we need to help the wound close. So instead of trying to force the edge to migrate, you need a new healing bridge between the base of the wound and the wall of the wound, okay? Like the edge of the wound. And this mechanism is based on wound healing biology and clinical observation, although it hasn't been validated in large controlled trials. So why does the wound edge matter? It matters a lot, okay? Especially for us as wound care specialists. So normal wound healing requires epithelial cells to migrate from the wound margin, okay? Think about the wound edge as the launching point for epithelialization. So if the wound edge is rolled in, which I don't want, thickened, fibrotic, callous, macerated, or hyperkeratotic, then the epithelial migration is actually impaired. And in some chronic wounds, the edge becomes an epibole, right? I never really used the word epibolized, okay, but it sounds cool. But yeah, epibolized, okay? I don't like an epibole, and that's what we actually talked. You will hear in the next episode of Limb Watch about, patients talking about thinking that the wound is getting bigger from the doctor debriding it, and that's not true because see, that's the whole point. The chronic wound wants you to think that it's getting better when it's epibolizing and you're thinking that this is nice, healthy skin, but it's not. It's never going to fully close if it has an epibole on that area. So you have to remove the epibole. So instead of the epidermis extending across the wound bed, that wound edge is rolled under. And that edge of the wound where the keratinocytes can migrate, that's rolled underneath, okay? Do you ever try to walk over a rolled edge carpet? That's not fun, right? You trip, you can't move, nothing can move over that, okay? So the epithelial cells are essentially going in the wrong direction. They're going underneath, okay? This creates this critical question: can a wound close if the cells that are responsible for the closure can't properly migrate over the wound bed? And that's why we love me some debridement. So the biology of the wound edge. So wound healing occurs in overlapping phases. We know the four phases: hemostasis, inflammation, proliferation, and remodeling. And during the amazing, my favorite proliferative phase, the keratinocytes migrate across the wound. The wound edge is therefore biologically active. And in a chronic wound, it can become trapped in this persistent inflammatory state, which a lot of diabetic foot ulcers are stuck in. And the edge can contain these senescent, oh, forgive me, cells, excessive proteases, chronic inflammatory mediators, abnormal extracellular matrix, as well as fibrotic tissue. And the result is the wound can become stuck. The wound may not necessarily be dirty, but it becomes biologically dysfunctional. So I want patients to understand and people to understand there's a huge science behind wound care, and there's a huge science between why we need the curette or the scalpel to take away this wound edge that is rolled under and trying to just establish it as just a chronic wound. We do not want a chronic wound. We want a acute wound and a nice healthy wound where we can restart the wound to say, hey, epithelialize over and fully close. Okay. Now, the trench. The term trenching is particularly interesting because it implies that the clinician is creating or enlarging controlled groove along the wound margin. The goal is not simply to make the wound larger. The goal is to expose. That's the whole point about debridement. Remove the non-viable tissue, but also expose the viable tissue, the good ones, the healthy ones, the strong soldiers, and establish a functional wound margin. And this is a key distinction. You're not just making the wound bigger, you're potentially removing all the non viable edge tissue, removing restrictive tissue, addressing a rolled wound margin, opening, hitting, undermining, and creating a clearer transition between viable and non viable tissue. The wound may initially look bigger, but the goal is to create a wound that is biologically active and capable of closing. So how is the procedure performed? Okay. In the publication, the equipment is a small dermal curette, about 2 to 3 millimeters for shallow wounds and 4 to 5 millimeters for deeper wounds. And the technique is perform standard sharp debridement first, and then identify the junction where the wound floor meets the vertical wall, and then place the curette at that junction, excavate a narrow trench circumferentially around the wound, remove approximately 50% of the wound base, approximately 50% of the wound wall, and repeat every 1 to 2 weeks if needed, and then continue until visible and viable continuity develops between the wound edge and the wound bed. And the trench is intentionally shallow and narrow, and it's not this extensive excision of healthy tissue. So let's do a clinical application. So let's bring the diabetic foot in it. Consider a patient with type 2 diabetes, peripheral neuropathy, a chronic plantar ulcer, 8 weeks of wound care, no opposite clinical infection, adequate perfusion, appropriate dressing, and inconsistent offloading. So the wound has been plateaued. So the center looks generally healthy, but the edge of the wound is thick, callous, rolled, and fibrotic. We see this all the time, especially with diabetic foot ulcers and especially neuropathic ulcers. The clinician may ask, why isn't this wound healing? Possible answer is the wound edge may be dysfunctional, and that's what we're trying to remove, the dysfunctional wound edge. Another question is, why did the edge become dysfunctional, right? Most likely because of the inconsistent offloading as well. This could be something we address, okay? But you gotta think about offloading. Remember, offloading is key. So you have to remember edge trenching does not fix pressure. So if we're doing edge trenching and we're removing that edge, right? And you're still not offloading, walking on that wound consistently without the proper footwear to offload that area, then it's pretty much a wasted effort, right? Because suppose a patient with a plantar ulcer, let's say the ulcer is underneath the second metatarsal head, we perform meticulous, beautiful edge debridement. The wound looks beautiful, mwah, bellissima. And right now, I did not say that properly. And the patient walks 10,000 steps the next day in the same shoe. Repetitive pressure remains. The wound edge does become traumatized, the wound does not close. And so the procedure wasn't necessarily a failure, but because the mechanical environment for the wound was disrupted and traumatic for the wound, it makes it hard. Okay. So we have to think about these pillars. The wound bed, is it viable? Is the tissue viable? Yeah. Is the wound edge? Can epithelialization occur? The wound environment, can the wound remain protected enough to heal? So we have to think about that. So we're back to this case. The second metatarsal head plantar ulcer is zero point 0.8 centimeters by zero point 0.7 centimeters. The patient is receiving local wound care, serial debridement, and moisture balance dressing. For several weeks, the wound stops. Okay, so the wound exam, the center of the wound is granular, viable, and free of any obvious signs of necrosis or non-viable tissue, but the wound edge is thickened, hyperkeratotic, slightly rolled in, and firm. And there is a small amount of undermining. And the question is the wound bed the problem? No, but probably not. It is the edge, okay? The edge is the problem. So what happens next? Okay. So the wound is follow up serially. We do the edge trenching procedure and we study every week, once a week, right? Because it's a nice small wound, it doesn't drain too much. So we evaluate the wound area, depth, edge characteristics. That is a big thing when it comes to documentation, edge characteristics, undermining, exudate, granulation tissue, and peri wound. The goal isn't simply is the wound smaller, the goal is the wound demonstrating biological progression. Sometimes things have to get bigger before they get better, right? So this is one of the most important ideas to explain to patients. After debridement, most likely your wound is going to look larger, okay? It's a procedure. We're removing all the devitalized tissue, but I promise, I want to say promise, but next week I know it's going to look much better. I know it's going to look prettier and healthier. Like I said, I always remember that story when I wasn't a student. It was like a few months after residency, but you're like doing things and learning in doctors' offices. And I'll never forget they did this huge debridement. It was just like a point 0.5 by point 0.5 wound and debrided it to make it look like a 2 centimeter by 2 centimeter wound. And the next week when the patient came, it looked like it was almost closed. And I realized, wow, debridement is a big deal. That made me understand how important debridement was because it looked better than it initially was when it first came, and it pretty much it was like point 0.1 by point 0.1 afterwards, like within a week, okay? that doesn't apply to everybody, but that showed me how amazing debridement is. And sometimes things get bigger before they get better. And just like we said, some patients be like, "Oh, the doctor made my wound bigger." That is not the case. Okay, they removed all the devitalized tissue. If there is vascular compromise, that's a whole different other thing, and that's causing gangrene, things like that. Or but but sometimes things have to get bigger before they get better. Okay. So I know it can be alarming to some patients, but the wound size is not just the whole story, okay? The whole point of debridement is for us to remove the non-viable tissue, the restricted tissue, and to make the wound biologically active and more viable and preparing for closure, okay? So we have to distinguish between wound enlargement due to tissue destruction, okay? Or wound enlargement due to removal of non-viable tissue. Those two are not the same, okay? So edge trenching versus standardized debridement. Okay, so traditional wound debridement, we focus on necrotic tissue, slough, biofilm, and non-viable. Edge trenching debridement focuses on the wound margins, the epiboli, the hyperkeratosis, the fibrosis, the undermining, and the restrictive edge tissue. So edge trenching, the concept further by intentionally targeting the margin and immediately adjacent tissue to establish a more functional, biologically active wound boundary, okay? Because this could be preventing the wound from progressing, okay? So, another thing we have to remember, wounds are not one size fits all, okay? Not every chronic wound needs edge trenching, okay? Wounds may fail because of ischemia, infection, osteomyelitis, pressure, edema, malnutrition, hyperglycemia, venous hypertension, autoimmune disease, malignancy. So if you're only treating the edge, you may miss the whole actual real problem. So that's why edge trenching should be considered within a comprehensive wound evaluation and assessment. Now, we already know vascular plays one of the biggest roles, okay? They're our sun when it comes to wound healing. Vascular is our sun. That's what I believe in my head, okay? But does this wound have enough blood flow to heal, okay? If their problem is insufficient perfusion, vascular, vascular, vascular. Say it 3 times, okay? So priority would have to be vascular assessment, toe pressure, transcutaneous skin perfusion pressure, vascular imaging, and revascularization if vascular recommends it for the patient, okay? Got to think about infection. If there is any infection around, if the wound has purulence, spreading erythema, increasing warm systemic symptoms, deep tissue involvement, we have to address the infection first, okay? Offloading, if the patient keeps on coming back in their own shoes, or you notice the wound dressing that you put on last week has a dirty bottom, right? Then we know you're walking on it, right? You have to remember pressure, shear forces, and repetitive trauma. That is not going to help the wound close. You're killing the baby skin cells, okay? So debridement without offloading is incomplete care. It doesn't work, okay? But why is trenching quite useful for diabetic foot ulcers? Plantar diabetic foot ulcers often do have these thick calluses, these deep vertical walls, significant undermining, okay? And like I said, sometimes traditional 45-degree edge beveling is sometimes impossible. So edge trenching attempts to create this biologically active transition zone between preserving the surrounding tissue. So, you got to think of wounds in a new way. Wounds are not a hole in the skin, okay? It's a biological system signal. That's what it is, okay? Now, when should you consider edge trenching? Chronic diabetic foot ulcers, a plantar ulcer with vertical walls, epiboli, hypergranulation that fails to connect the wound edges, deep wounds where beveling at 45 degrees would sacrifice too much tissue, or stalled wounds despite adequate perfusion, infection control, moisture balance, and offloading. So the biggest takeaway is edge trenching raises an important principle that the wound bed may be ready to heal while the wound edge may not. And a wound can have healthy granulation tissue, adequate moisture, adequate appropriate dressing and still fail to close. And sometimes the problem is the edge. And before we blame the edge, we also have to ask, is there adequate perfusion? Is there infection control, right? Source control. Is the wound being offloaded? Is this patient nutritionally and metabolically supported? Is this the correct diagnosis? Okay. Because a wound doesn't simply just heal because we debride it. It heals because of the biology, the blood flow, the mechanics, and the environment all align together. Okay. So the next time you look at a chronic wound, don't just look down, look around, look at the edge. Is it rolled? Is it fibrotic? Is it calloused? Is it undermined? Is it preventing epithelial migration, right? Because sometimes the biggest obstacle for wound closure isn't the middle of the wound, it's the right at the border of the wound. Edge trenching challenges the way we rethink debridement, okay? Maybe debridement isn't just about removing dead tissue, it's about creating the conditions for an alive alive cells to move forward, okay? Remember, a better wound edge cannot overcome ischemia, forgive me. Clean wound cannot overcome uncontrolled pressure. A perfect debridement cannot overcome untreated underlying cause, okay? Because in limb salvage, the question simply isn't did we debride the wound, right? The question is did we create a wound that has the ability to heal? That's the whole point of wound healing. So this is diabetic foot files because every wound has an edge, and sometimes that's where the story begins. And this is diabetic foot files. I'm Dr. G. Take care of your feet because they take care of you, and I hope everybody has a great weekend.